Other pregnancy considerations. I don't know if he's told you guys I'm getting over laryngitis, so bear with me. So co-management should be between an OBGYN, a maternal-fetal medicine specialist, a neurologist, and likely an ophthalmologist if there's issues with papilledema. All patients in pregnancy do get detailed ultrasounds around 18 to 20 weeks, so we can look at the baby from head to toe to see if there's anything going on with the baby, okay? And I say that because Diamox is well studied in pregnancy, but there are some studies that say, hey, babies that are born to moms that are on Diamox can have an increased risk of being smaller. And animal studies have shown that some of those babies have an increased risk of some defects, specifically spinal cord defects. So we want to make sure that moms do get a detailed ultrasound. Those studies in humans are not consistent as those in animals. And so I do recommend continuation of Diamox if a patient is on Diamox and needs Diamox in the pregnancy. Now, if a person got a preconception consultation and they did not have headaches, they were treated well with Diamox, and we can wean that and see if that helps, or if they've already had an optic nerve fenestration before pregnancy and they're asymptomatic, but their clinician has them on Diamox just as maintenance, we will see if we can wean that off, see if it can help. But if you haven't been weaned off of it before the pregnancy and you're weaned off of it at the beginning of pregnancy and you start to have issues with symptoms of increased intracranial pressure, i.e. headaches that are more frequent and pulsatile, then I would recommend continuing on that through the pregnancy. Now, once the patient reaches viability, which depends on where you are and where you practice, but where I practice, viability is 22 weeks and 5 days. Internationally, 23 weeks has been known to be sort of the cutoff of when patients are viable, when they're not. So that 23-week and 500-gram weight of a baby is usually when a baby is big enough to intervene and for us to intubate a baby to help a baby breathe. So once somebody reaches 23 weeks and 500 grams, then we will be doing growth scans serially to look at the size of the baby because, again, Diamox in itself can put a baby at increased risk of being smaller. People with IIH in general also can have an increased risk of having a preterm birth and having a smaller baby. So we want to monitor you through the pregnancy. But for the most part, people with IIH do very well, and their pregnancy outcomes are generally the same as people that don't have IIH. So other comments, and I say this because I've seen crazy things, and I feel like I need to put it out there so people can know and advocate for themselves. Some people think because you have IIH, you can't have an epidural. That is not true. You can have an epidural, okay? Actually, it probably will help with your headache. So you can have an epidural. Patients can deliver vaginally. People think because you're pushing, that may put too much intracranial pressure and cause you to have issues with worsening visual acuity. That's usually generally not the case. There's a couple of exceptions to that. Meaning if a patient needed a diversion surgery because they had such high intracranial pressure that they're having visual loss, and they refuse to do it during the pregnancy, which means that your intracranial pressure is high, then you may need what's called an operative vaginal delivery, meaning once your baby is complete and crowning, we may need to do something like a vacuum assistance, meaning it's like a little suction we put on the baby's head, and then we help you by pulling the baby down the birth canal or back down into the vagina and out while you are pushing so that you don't have to exert as much intracranial pressure. The other alternative is to go straight to C-section so that you won't push at all. But that's only with people that have extremely severe intracranial pressure, signs and symptoms of papilledema with evidence of vision loss. Those are usually the only people that cannot deliver vaginally. Of course, if you have other reasons for needing a vaginal a C-section, like you've already had a C-section before, or if you have had a myomectomy or any surgeries on your uterus, then obviously those are reasons that you may need a C-section. But if you don't have anything else going on and you have IIH, you can deliver vaginally unless, like I say, it's an extreme case. The visual outcomes are actually the same during pregnancy as they are when you're not pregnant. Okay, so pregnancy is not going to worsen the progression of visual loss in people with IIH. That is not true. They usually do the same. So if you had worsening visual acuity before pregnancy, it's going to progress during pregnancy. So it's better to get a preconception consultation and get that treated before pregnancy if possible. And then the rate of miscarriage is not increased with IIH. People with IIH have the same rate of miscarriage as people without IIH. This does not increase your risk of a poor pregnancy outcome related to stillbirth or miscarriage.